So today has just been one amazing presentation after the other. And we're not done yet. We're not done yet. Every time you read a book, you take something different from it. Just like when you read a movie, you watch a movie, sometimes you see something different the second time you look than you did the first time. The author of the novel may intend one thing, and me as a reader, I may have picked up something totally different. And that is what I love about reading. That's why I read everything from bus tickets to, you know, the package of the chewing gum, and I'm averaging a book a day. It's a beautiful thing, and we never stop learning if we keep reading. That book informed a lot of the conference, and a lot of the conference is how we as people and how we as physicians miss or deliberately ignore cues and clues that we need to observe. And whether it is in inattention, we're harming children, or we're harming women, or we're harming the lives and the health of our patient because we choose to do one thing when all evidence points to another thing. I think this is just such a perfect sentinel call to wake up. The evidence is out there in medicine. The trials are there, the data is there, it's right there for us to see. And if we keep practicing the way we've always done it, just because that's the way it's always been done, if we ignore the cues and the clues that patients' bodies are giving us, if we ignore what women are telling us when they come and sit in our chairs and lay on our, couches, then we will continue to practice bad medicine. And the best doctors, if we fail to observe the evidence, will always practice bad medicine. So once again, thank you, Melanie. That was amazing. Thank you. All right. Wow. Okay, so we're moving right along quickly now to, we would like Carlos. We'd like Carlos Maita from RESMed to come on to the stage, and he's going to speak to us about adaptive ventilation therapy, when, how, and why. And of course, doing the typical English thing, I actually missed the last name, didn't I? And it's Carlos Resendiz Maita.
Thank you. Thank you so much. Well, it's truly a pleasure, an honor to be surrounded with so many charismatic, smart, and rich people that we can now share a lot of knowledge. And I hope that this could be interesting for everybody, because it's totally aligned with all the conversation that we have been talking right now. And so we are just going to be a little about some sleep technology. So did you have a really good night last night? Did you sleep well? Somebody sleep well in the house? Yes, good. It was a really good night, and I hope that you get like more than 5 hours of sleep. But if it's not, doesn't matter. We're gonna get more maybe tonight or tomorrow. Bye. Okay, so let's start with this. Okay, the main objectives is going to be really easy, really straightforward, all the conversation. Just some pathology about central apnea and some how to prevent it, and the report of the prevalence that we have, that is really interesting. Learn how the ASV work. So it's going to be like a bit of technicals in the middle, and a review of ASV indications and contraindications, of course, of when and why you have to put and you have to treat the patient with central sleep apnea with this, okay? So to understand all these therapies, we have to know specific just one thing, that as you know, this is not going to be that much. It's just the basics. The respiratory center, we're going to have these sensors that help us to inhibit and activate the muscles just to breathe, of course. And then we have the hole in the middle, in the heart, and each part of the artery. We have some other how to measure the oxygen and the pH. So if this, of course, if this doesn't work, if this any part of the artery have any problem, of course, it's going to be a consequence. And the thing is that the main consequence of this gets some specific ways to read how blood it is going and how, if any medication, it's getting some troubles with the breathing, and if there is an impact, obviously, in hypertension and heart failure. So the damage of the respiratory center, like a stroke or a trauma, can also affect sleep apnea, central sleep apnea. Okay, and if we can keep going, of course, there's like the threshold, the apneic threshold that we have, depends in how high could be the level of CO2. So we now can learn which part could be better to know and to understand it through a sleep test. And of course, the normal apnea, we can find it over there. The central apnea, of course, when they goes really down, so that's a like normal response. So, because we know this, and we know that ventilation can decrease a lot of the respiratory parts and small ventilation index. Okay, we have like the whole reduction of the volume and the minute volume that the patient goes through the night. Okay, obviously the response will be to increase the upper way resistance and alter the chest wall mechanism. So now, as we know the basics, and we all know that, so the central apnea activity could be also like going really deep through the ocean, because you change the levels. Of course, we're going to have some consequences about that. And of course, if you go really up, like where I live in Mexico City, it's like 2,300 meters above the sea, and there's when also an apnea, central apnea activities, because the altitude. And just in case, as you know, if you know this instrument, it's a didgeridoo. It's an amazing instrument, and it's also related and with sleep apneas and some other kind of sleep mechanism that we can enhance by doing this kind of music or play an instrument like a trumpet or something like that. Could be an interesting thing. It's another part of the activities that we can do. And central sleep apnea is not the biggest respiratory disease in the whole picture. As you know, probably more than one, obviously, have some sleep disorders in this room. So how many people do snore? Can you raise your hand? It's as easy. It's not going to be that. It's not that complicated. It's statistically impossible that nobody snore here in the room. It's like I snored when I was a little kid because I had a big, amygdalas, and it was the problem, and they took it off, and now I don't have sleep disorders, or respiratory sleep disorder. But probably a lot of you know or have this disease. Yesterday we did a trial for OSA with one of the cameragraphers from the whole event, and he told us that he really needed, because change your life. And you have central sleep apnea, is going to be another kind of really bad situation, because if you don't treat it, it's going to be worse. So the impact of all of this is that in the center of the whole situation, specifically during the certain parts of people with heart disorders, going to have this kind of disease or this kind of sleep disorder. The other thing is that depends in some other considerations, like if you have some more than the half of your sleep apneas are central apneas, there is when you're going to be in trouble, because you need to attend those kind of sleep apneas. And obviously, unstable ventilatory control during a sleep mark, that will be another situation. So part of this the whole conversation is that there's two types of considerations for levels of the PCO2 levels. There's going to be the normal capnic that could have low arterial PCO2. So this will be just for the specific persons that need a ASV. Okay, with an ASV you can treat perfectly this kind of populations. Okay, and hypercapnics, you just need like the normal standard biolevels that can have this mechanism for treat their sleep disorder. So the first part, what we want to know is that which kind of people or subgroups that will need to treat the sleep apneas. And part of it, of course, we have to know that 6.5% of the people that have SDBs will have complex sleep apnea. That is like a lot of snoring and a lot of apneas during the whole night. It's like nightmare, for real. This is not really easy for this kind of people, but it's just the lowest part. The most important part could be on the opioid patients that have these consequences because of the drug. And also the people with heart failure, but with a prevalent ejection fraction from the left ventricle will be the main characteristics for all the conversation that today we had in the last conferences. And talking about the prevalence in women, it's crazy. I was just looking for that also, and all the people that have heart failure, but in that specific prevalence, it's really interesting in different kind of countries. Of course, part of the symptoms that we have, we can misunderstand these kind of symptoms with other kind of situations. If you don't sleep well, of course you're going to be with mood changes, and of course you're going to be really tired all day. But the thing is that poor memory and concentration could be really a bad consequence in the long term. Okay, so at night, of course, it's going to be also real difficult to you to get really a good sleep to get the next morning. But part of this is the indications. So when you have any patients, I don't know, there is some sleep doctors here, or you treat some part of the diagnosis, or you have any, but because if I ask, do you have any patient with heart failure? Probably, yeah, a lot of you have those kind of patients. And if you have these kind of patients with a prevalent ejection fraction, probably you will have a patient with sleep apnea, central sleep apnea, that will have a lot of bad consequences in the long term. So the whole situation of doing a servo ventilation, they had a really interesting article that is the famous Servo HF. This one study patients a lot along the different countries. It was a multi-center study that showed how the use of ASV helps you to treat the central sleep apnea. And it was really confusing because the whole number of people over there had a ejection fraction less than 45. So actually the whole population have this kind of bad consequences in some specific group that doesn't have like the less than 45% of the ejection fraction from the left ventricle. So these patients are totally excluded because they found that the mortality goes up in that specific group that have less than 45%. So in the study, effectively, they controlled the central sleep apnea with this machine. But the thing is that in different populations that have the therapeutical goals, or that doesn't get in this kind of group, well, in the whole situation, the therapeutical goals, of course, is the same as you have been told. The reduce of the events, everything else, the maintenance of the minute ventilation, and that's the key. Because if you know, if you have a really good sleep and good breathing through the sleep, you will have the benefits of, the whole stabilization of your life. So in this kind of equipment, you have to consider the weight of your patient and if they have an obstructive sleep apnea or probably the central apnea. Okay, that's the main thing that you have to consider. And it is intended to use at home at the hospital. And the contraindications are as I told, it is the patients that have less than this ejection fraction percentage will be the people with also chain stocks, that pattern breathing that have this kind of patients sometimes. That's the population that could be out of this kind of treatment. But there's a lot of people that it includes in this and excludes this kind of indication. Because if you say, as Dr. Holgen Wallace said, that it's important that we don't extrapolate these findings beyond the specific population and parameters that were investigated in the SERVO-HF, because it was just for knowing the benefits of treating sleep apnea. And they found another thing, but they have a lot of good information that says that you can use it and you can improve their life and be in control in different other hard consequences that sleep apneas and central sleep apneas have in the cardiovascular system. So it's really easy to notice and how you're gonna treat the patient. At the first time, you have to be sure that if there's any diagnosis of heart failure, if it's okay and you don't have any risk for heart failure, you can go straight to the treatment. And if you have, you're really unsure for how is this patient being diagnosed, so you have to go through the whole way to clarify this specific contradiction. Okay? So, and the remaining is the high prevalence. It's, as I told, it's kind of the same analysis that we did just a minute ago. So you have to consider that treating complex sleep apnea patients with a normal CPAP could be not that effective, because almost like 83% of the complex sleep apnea patients that use it were getting really good results from at the end of the study. And the people that used the CPAP was really not able to maintain the treatment, because the CPAP is not enough. CPAP is just positive air pressure, and the ASV, it's pressure support being fixed, and at the same time being servo-adaptative automatically. So the other part is the opioids patients, that it's kind of the same situation, comparing ASV versus ST, that it's another kind of treatment for central sleep apnea. But this mode, ST, is not that effective because it doesn't measure the minute volume that goes through the patient in the whole night and going breath by breath. So now that we know that it's really effective to use ASV, we know that if you have patients with chronic and profound hypoventilation, and if there's restricted thoracic neuromuscular diseases or COPD, you should not be using ASV, okay? So this is a quick video that will be, I think it doesn't run, but it's okay. It's just an example of how it works, the algorithm specifically. And it's really easy to understand it because it just has three main characteristics: to learn and create a ventilation, to monitor the response, and to predict and optimize the respiration through the night. So in the first part, learn and create, it's how the minute ventilation goes through different points and measure 3 minutes average minute ventilation through all the night. So it's a really high resolution learning in this algorithm. And taking that as an advantage, we use it and we measure it so they can be more specific, because as you can see, there's a limit, flow limitation breathing, and there's a normal breathing over here, and both have the same peak flow, but the difference is inside the whole breathing curve, okay? So the second is the monitor and response, just monitoring through the night, and you will see that how it's getting, okay? I'm just gonna pump up through the conclusions of how this whole algorithm it's good for all the kind of patients with this kind of situation and heart failure, because it's really easy. It's fast. It goes through the night and help you like these examples. You have the flow, you have the pressure, and helps you to maintain and stabilize. Okay. In the same scenario, just to keep on going with this, it's how pressure support goes and increase and stabilize your mean ventilation. And of course, how the response is perfectly clear while the central sleep apnea is going on, or maybe an obstructive. So you can treat both of it, okay? And the prediction and optimization of an easy breath technology, okay? Well, this is just the end of a whole ASV knowledge, and just for the conclusion is that we must, and now these days with all the technology, we have phones, we have everything, we have internet, and the main thing is that this equipment, each of one have built-in a wireless communication, so you can be connected with the patient. It doesn't matter where, but you can be with the patient and do a remote assist every day. So this is a really good improvement for technology now these days, using wireless communication for your patients and for you to keep on monitoring. And of course, having the technology at the hand so you can make better choices and keep on treating your patients so they can improve life, okay? And that's it. The step one, just take sure you have the main equipment. You analyze it. They have the sleep central apnea. Step two, if the patient has a lot of sleep apnea, just treat it with the correct device, that is the ASV. Of course, taking in consideration the 45%, left ventricular ejection fraction. And that's it. Really thank you for your attention. And if you have any questions, I'll be right back over there.
Okay, thank you. Time is not our friend.